which kind of leads into Dr. Logmahnee here. I had the privilege of meeting him several years ago when we were helping support some pilot projects at Lurie Children's Hospital in Chicago, Northwestern. And we all kept in touch and to be involved with Darius here to explore how to scale up and bringing it to an entire health system, which could be the size of a population of a country. So thank you very much for being here.
Thanks, everybody. I am so grateful to be invited. So grateful that I almost got a haircut, but I did not do that. I have no conflicts of interest. So if we think about it, the current state of what we're doing in terms of the orofacial myofunctional therapy, we know that it's important, right? We have a room full of people. We have people that are watching this in live stream. Increasingly, people are interested in this approach. The prevalence of orofacial myofunctional disorders is not known yet, so we don't know that. The number of practitioners, who is doing the work, who should be doing the work, that's not yet clearly defined. And in terms of training programs, we don't necessarily have very like a certification process that crosses all the different disciplines that actually look at orofacial myofunctional disorders. The question about certification becomes really important because we have to balance the idea of excellence, right? We want to make sure that when somebody, like when Japan's government says we are now paying for treatment, orofacial myofunctional treatment, where are they going to get that? Who's going to provide that? How do we know that it's actually meeting a standard? So there's definitely there are pros and there are cons to this. The pros are you're going to ensure quality. And so you'll be able to say, like, people are going to at least be able to do these things. It also allows us to define a cohort, right? Like if we were to get like somebody called you from somewhere in the Ozarks Mountain. We said, I have a kid who has a lip tie. Where should I send them? We don't know. We don't know where we would send them. We don't know anybody there. So certification allows us to know where are the people that are doing this work and that are interested and capable of doing this work. It also excludes charlatans, right? So charlatans, I chose that word because I haven't said that in like a public setting like this before. So that word I think is interesting. But the idea is just this idea, because you can say like, I do orofacial myofunctional therapy. You can just say that and say, send me your patients. And there's no way to actually know who's doing that. The cons, though, you don't always ensure quality, right? Like a lot of people are actually certified to do things that they shouldn't do. Like I'm licensed to do both as a physician and a surgeon in Illinois. But don't send, I'm not going to do surgery. It's, I shouldn't do that. The definition of a cohort can be useful, but it can also become a problem because it can limit participation. And when you start to exclude some people, you always start to miss, right? So there are some people, like we had one of our best pediatric sleep techs was actually not a certified sleep tech. And so she had been doing the work for 20 years, was the person that trained everybody else and helped them pass their boards and get their certification. And so like if we were to say, unless you're certified, you can't work here, we would lose one of our best techs. So I think we all know some people that are involved in this work that are really amazing and that may not actually meet criteria where we to set them for certification. So the problem is when we're talking about excluding participants, we're not in a position to do that. Dr. Bhattacharjee shared the numbers. If you look at just in Illinois, we have about, using the low end, the conservative measure, we're looking at 93,000 kids that have sleep apnea. So if you're thinking about treating them weekly for 6 months, one full-time provider would be able to look at 140 patients a year. So we would need 664 full-time myofunctional therapists just to cover obstructive sleep apnea. That's not including the 217,000 kids that are snoring in Illinois. I mean, I don't know all of them. We're just running the numbers. But essentially, you understand the point. We can't actually get to scale at this point. We don't have the number of people. In order to respond to this demand, we have to start looking at a couple of questions. One is, who is it that's actually qualified to evaluate and treat these disorders? Is there a validated treatment protocol? And are people even aware that this is something that they should be thinking about? Because mouth breathing isn't something that everybody commonly recognizes as an issue. It's something that we should be thinking about as, why is that happening? Maybe we should, maybe we should change it. So in order to advance understanding, we want to try and help grow our own understanding as a field, as multiple fields that are all intersecting here. We have to create a culture of appreciation, encouragement, and humility, right? And the humility, and when we're talking about data, we really have to be humble, right? Like the chat study had hundreds of patients, right? But that's still just hundreds, it's not thousands, right? And even the studies that have thousands, it's not millions, right? Anytime like we're thinking about what we're doing, we're humble in our offering, right? We don't say this is how it is and it'll be like this forever. We say this is our current conception of what's in front of us, knowing that it's going to evolve. We have to start to identify key questions, right? Rather than just saying these are the answers that we know, we're now giving you these answers, we're identifying the questions and we're really inviting participation. Anyone who has access to a child, anyone who has access to hearing about a child's sleep, those are people that we want to be connected to them. We want to be able to hear from them. And to be able to help them participate in these spaces effectively, we have to train them. They have to have certain skills and attitudes and qualities to be able to participate in the learning process. This is one thing that I just wanted to share a brief experience that we've had at Advocate Children's. So we know we have 290,000 kids that we're actually financially responsible for. So the insurance companies have given us the money and they said, okay, for the next year, you guys are responsible for any costs that come. Of that population, somewhere between 5,800 and 14,500 of those kids have sleep apnea. So if you look at St. Elsewhere, which is a competitor pediatric sleep hospital in Chicago that we don't use the name because it's the competitor. They ran 2,600 sleep studies last year, right? And so even just that number that they ran with their 3 sleep doctors, and we have one, we have more than double that number of patients with sleep apnea. But you don't run sleep studies on people with sleep apnea. If you know that they have it, you don't have to do the test. So you actually have to run the sleep studies on the kids that are snoring. So that's somewhere between 20,300 and 34,800. So that's a lot more sleep studies than we're ready to be able to do. And if you add in behavioral sleep issues, so 72,000 to 120,000, we have a lot of kids with sleep disorders in this population just because sleep disorders now are endemic, right? You look at how much caffeine people take. So we had to actually shift. We had to shift away from this idea of thinking that pediatric specialists are going to own and do all this work ourselves. We had to say we're going to partner with the adult sleep specialists. This is another group that we'd rather not work with because... And so so they are always willing. Adult sleep specialists are always really willing to come in and partner with us. For a long time, we were saying you can't do this because you do it the same way. You try and score a ped study like you score an adult study. It's a completely different thing. So instead, what we've said is you're welcome to join us. This is how we do it. Let's think together about this. Pediatric subspecialists in our system now, we see them as partners as well. So they'll send patients directly to our lab. We consider them consultants. Increasingly, primary care providers are doing the screening and the evaluation of children with sleep disorders and are starting to send us. And we have a couple that we've been able to develop relationships with and to help them actually start to work as primary, as sleep physicians almost, like for specific disorders. Nursing, who's actually asking these questions? Who's close to the parents? Families, communities, teachers. Teachers are in a remarkably unique position, right? They know the kids who have attention problems. They know the kids that are breathing through their mouths. There's been experience in Brazil with myofunctional therapy, working through networks of teachers. And then patients themselves. If we start to look at all of these people as collaborators, this is our work, right? We identify questions and we invite anyone. We see everyone as a potential collaborator. Because children exist within a community. In that community, there are institutions, there are schools, there are hospitals, there are museums, there are allied health professionals. These are physical therapists. These are the nurses, the school nurses, the speech therapists, the myofunctional therapists. We don't know where we would actually find them, right? So this is where the process of kind of defining that cohort, I think that's going forward and it'll continue to go forward, but I don't think that's our work right now. The most urgent work right now is to make sure that as many people as possible are actually aware of what's happening and that the relationships between all of these different fields are strong and that we have a common purpose, we have a common interest, and we're able to work together in that way. Because if you look at it, if we think about a pyramid, we want everyone aware. We want the widest base possible. As many people as possible aware that that myofunctional therapy is an important field, and mouth breathing and nasal disuse are things we want to address. To be able to help them screen effectively. what are the questions that help us identify somebody that's mouth breathing even? Like if we were to pick up the phone and call somebody, could we say, does your child do X? And they'll be like, yes, and we'll say that's a mouth breather. How do we start to identify those questions? How do you actually help somebody know how to triage a kid? So a kid that screens positive or doesn't have any other symptoms, at what level of care do they have to go? Does everyone need a sleep study? Probably not. To evaluate and treat, and then finally to train. Who are the people that are going to be able to build this capacity in a growing number of people, to think systematically, to think and act systematically in this work? We want as many people as possible to move up this pyramid. So to increase access, because we want to maintain the standard of excellence, we also want to know that we're growing, we're moving towards that with the idea of access being at the heart of this. We want to make sure that this treatment is available to as many people as possible. We need strong collaboration, we need training at all levels, and really, hopefully, we'll have more and more spaces where we can have reflection, be able to come together and think about some of these questions together. Because like the talks that we've heard this morning, I mean, I have all these new ideas and questions that I want to ask. I want to be able to know that in a couple of months we'll be able to come together and say, okay, what have people been learning? What's the next thing? So that I can both contribute, like what I've been seeing, but also to hear what others have been seeing. You know, I think it would be very interesting if we could start to imagine a space where rather than thinking about just having one person up here with lights in his eyes talking and to a microphone and you guys all sitting there, but what if we were sitting in circles, sitting where every voice could be heard, and all the knowledge that I know is in so many of you could be accessible to everybody. Right, so really that's the challenge that I have for the Academy, is how can we actually start to reimagine what spaces like this could look like, where we could actually hear from more and more people as more and more people come into this work. So it's a privilege to be here. It's really exciting, right? Because we're all among friends. This is all people that really are really excited about this new and emerging field and are thinking together about how to advance it. So thank you for having me. Thanks,
Thank you very much, Darius. Just a couple of points as we're about to head into break. You know, it's extraordinary to look at this. Like I mentioned at the beginning of this symposium, yesterday we agreed to found an international research network, and we're going to be doing a validation study on myofunctional therapy. It'll be the first one to actually have a validation study of an entire therapeutic technique, and it will heavily weight around sleep, both pediatric and adult. But to have these kind of questions around, you know, how do we bring this to the population at large? Larger questions. How do we help as many kids as possible at the earliest possible age? You know, these are profound questions. And, you know, the person who actually brought me to that question and that statement, Dr. Kevin Boyd, will be speaking right after the break.